so we can move on to the first presentation about clinical landscape in anemic myelofibrosis. So these are my disclosures. So just briefly to mention the pathophysiology of this disease, myelofibrosis, that obviously is driven by a series of driver mutations in the genes, mainly JAK2, MPL, and CALR, that lead first to a proliferation, a myeloproliferation. But as you can see on the right part of this, this slide, there are other mechanisms, including the development of fibrosis that is due to a series of inflammatory cytokines, proteases, etc., development of osteosclerosis, stem cell mobilization, neoangiogenesis. So altogether, we have three main manifestations that are extramedullary hematopoiesis that manifest mostly by splenomegaly and sometimes hepatomegaly, inefficient hematopoiesis that lead usually to the progressive development of cytopenias, and constitutional symptoms that are mostly driven by the inflammation and inflammatory cytokines. Regarding anemia, you can see on the top left of the slide, the proportion of patients with anemia at presentation, which is already near from 40%, a little less than 40%. And you can see below the graph regarding the number of transfusions per year, increasing over time. And on the right, curves, survival curves, you can see the impact of anemia for these patients. Patients without anemia, for example, in this study by the Mayo Clinic, showed a median survival of around 8 years, and you can see a progressive decrease in this overall survival regarding in the presence of anemia and, or more importantly, on the degree of anemia. Even mild anemia reduces almost by half the overall survival, the median survival. But patients with severe anemia, the median survival of around 2 years compared to almost 8 years for patients with no anemia. And this is with an hemoglobin threshold of 10 grams per deciliter. So there's a clear impact of anemia on the survival of these patients. And indeed, this is the same for thrombocytopenia. And the most recent NCCN guidelines have included the cytopenias, for example, here, the platelet threshold in the decision algorithm for decision-making of treatment of patients. And if we look, for example, for patients who have more than 50,000 platelets, of course, we should always ask for high-risk patients if they are eligible for allogeneic stem cell transplantation. If not, the current recommendations are to start with ruxolitinib or fedratinib, or sometimes clinical trial. Monitor the response, and in case of absence of response or loss of response, then to switch to an alternate JAK inhibitor or a clinical trial. So what are the limitations of these strategies, especially regarding ruxolitinib? As you know, one main limitation that was already found in the early trials, that's COMFORT-1 and COMFORT-2, are cytopenias, and in particular anemia and thrombocytopenia that develop usually very quickly after introduction of the treatment, sometimes recover after 3 to 6 months of treatment, but sometimes not. And this clearly is a limitation for the use of this drug. We know that the drug is very efficient to reduce the spleen size and the symptom burden, and higher the dose you give, better the response in terms of splenomegaly and reduction and symptom burden. But in parallel, the price to pay, I would say, due to the mechanism of action by JAK2 inhibition, is the development of cytopenias. And you have to find the right balance between efficacy and this toxicity and development of cytopenia to choose the best treatment. And sometimes you cannot use the drug at an efficient dose to achieve spleen response because of cytopenia. The same occurred with fedratinib. You know that this drug is also approved as first-line therapy for these patients, but we also have a quite high incidence of anemia and thrombocytopenia with this drug. So this may not be the best answer to patients with anemic myelofibrosis or thrombocytopenic myelofibrosis. And as I tried to explain, cytopenia is a combination both of the disease itself and may be worsened by the treatment of myelofibrosis, especially by these two JAK inhibitors that we had first approved. So we have to find new options to address the burden of cytopenia in patients with myelofibrosis. Regarding anemia, besides of the JAK inhibitors or the treatment of the disease itself, we have some drugs that may help and to manage anemia, symptomatic drugs. And currently, the NCCN guidelines for MF-associated anemia recommend first, obviously, to rule out other coexisting causes, because these patients may have iron deficiency, may bleed, may have hemolysis that is found in about 10% of patients with myelofibrosis. So, of course, we have to identify and treat these coexisting causes, replacement therapy, treat hemolysis, etc. And then the guidelines suggest to rely on the endogenous serum erythropoietin level of your patients. If it's low, just like in MDS, for example, then you could try an erythropoietin stimulating agents like darbepoetin alpha, epoetin alpha, etc., or clinical trial. And if the serum EPO at baseline is elevated above 500 millunits per ml, for example, the alternative choices are androgens, danazols, imids, lenalidomide, thalidomide at low dose, sometimes with prednisone, luspatercept, or obviously a clinical trial. But this will be addressed by Dr. Fleischman later in the presentation. Another chance, if we look at the 4 JAK inhibitors that are mostly now available in the US and not yet in the Europe, but you can see that one main difference in the kinases that they can inhibit is that 2 of them, pacritinib and momelotinib, also target ACVR1. What is ACVR1? Indeed, this receptor that is at the surface of hepatocyte, not of hematopoietic stem cells, is indeed involved in inflammation. And when you activate with inflammatory cytokines ACVR1, you will induce the production of hepcidin. Then this will deregulate the iron hemostasis and induce anemia. So if you inhibit ACVR1, for example, with momelotinib or pacritinib, you will decrease the hepcidin level and make iron available for the erythropoiesis, and then correct or improve the anemia in these patients. And indeed, this was the case with momelotinib. You know that momelotinib is a JAK1, JAK2 inhibitor, but also an ACVR1 inhibitor that was approved last September in the United States by the FDA, and more recently in February by the European Medicine Agency for the treatment of patients with myelofibrosis and anemia, specifically for this subset of patients. This was based on a series of clinical trials, the early phase 3 trials, Simplify-1 and Simplify-2, that were completed a long time ago, and more recent Momentum phase 3 that compared momelotinib to danazol for patients with myelofibrosis and anemia. You can see on this slide, I try to summarize the main results of these 3 clinical trials. And if we focus on the last one, Momentum, on the bottom of the table, that indeed was served as a basis also for registration and approval of this drug. You can see that momelotinib compared to danazol in patients who already failed on JAK inhibitor prior study entry and who were anemic with less than 10 grams of hemoglobin. Indeed, momelotinib was able to produce a reduction in the spleen volume of 35% at 24 weeks in 23% of patients compared to 3% in the danazol arm, and also improve the symptoms with 25% of patients having at least 50% reduction in their total symptom score compared to 9% in the danazol arm. In addition, the drug was able to improve transfusion independency with 30.8% of patients achieving transfusion independence versus 20% in the danazol arm, showing non-inferiority of the drug compared to danazol. The most frequent adverse events were obviously anemia, thrombocytopenia, and infection, but you can see, on these graphs on the left, that transfusion independence on the left was achieved, as I mentioned, in 30% of patients compared to 30% at study entry, compared to only a 5% increase with danazol in this rate of patients who were transfusion independent. On the right, you can see on the graph in the blue line, a very rapid increase of the mean hemoglobin level after less than 4 weeks of treatment that remains stable over time, compared to less rapid and less marked increase with the danazol, that's the yellow line. And interestingly, after 24 weeks, patients were able to switch from danazol to momelotinib, and you can see that the curve of these patients then could reach almost the same level at 48 weeks of treatment. So altogether, I think that cytopenic myelofibrosis represents a major unmet medical need, and that we have now several therapeutic options that are investigated or are now approved, including JAK inhibitors, pacritinib and momelotinib. Pacritinib, as this will be shown by Dr. Fleischman, showed that it was a useful option for patients with severe thrombocytopenia. And on the other hand, Simplify and Momentum studies showed that momelotinib could induce transfusion independence in anemic patients while also reducing splenomegaly and improving symptoms.